conformal radiation therapy as opposed to IMRT. And we'll do some IGRT as well while we're there. So can anybody tell me what the difference is between conformal IMRT or conformal radiation therapy or IMRT? Anybody? No? Really? Conformal was what was called 3D or three-dimensional. We started off with 2D, which is basically APPA. And then we went to 3D. And then we went to IMRT. Can we do IMRT with cerebellum blocks? Everybody who's in clinic at the moment has seen an IMRT setup. What does IMRT setup look like? You're all doing this, I'm not hearing any words.
Your MLCs.
You can do MLCs with 3D, or you can do 3D with MLC. What's the difference? What does IMRT with MLC look like?
Screen, and then it goes like the things go back.
Tell me, those
Yeah,
people
tell
who
her.
are been in clinic, tell me what you have seen treated with IMRT. I'll go get them. Think about that and I'll be back.
Can we just take our phone?
Yeah, let's just
No, unfortunately not. If Dr. Henning sees us, we'll be all in deep podcasts.
You will, we probably won't. We pay him, what are we gonna get in trouble for?
Is it breast treated IMRT?
Wait, what?
I think so.
Isn't the
I think
CDC
pretty much
say?
everybody is IMRT. But they also do tangent.
Okay.
I don't know, I've just seen brains.
What have you seen treated with IMRT?
Breast.
Breast,
Brains.
brain,
Prostate,
prostate.
lung,
Yeah, I think one of our only ones.
sacral.
Basically anything these days is treated with IMRT. Now breast I'll leave because breast is kind of weird, so we'll leave that for the moment. Most of the time, breast can be treated just as well with 3D. And that's just because of where the location is. So when we are treating, let's say prostate or brain, what does that look like? What happens? You position the patient with a 3-point setup or triangulation, same thing, onto your marks or tattoos, whatever they have. Then what? What happens? You go out of the room, you shut the door, you switch on the machine. What happens? You're looking at the MLC and you're looking at the patient. The patient, does the machine stay in one place? Or does it do one place, does it sit here and then move to here and then move to here and then move to here? Or does it do a rotation? What's the rotation called? VMAT. And I know that you're gonna hate me for this, but what does VMAT stand for?
volumetric modulator up there.
Yes. Remember that. Sometimes called rapid arc. Rapid arc was coined by the Varian people.
That's what they call it at Flagler's, like the arc.
What?
That's what they call it at Flagler's, rapid arc.
Yeah, rapid arc. Although they have, rapid arc was around for several years before VMAT was coined. It's like a vacuum
My
cleaner.
machine doesn't do that.
VMAT is like a vacuum cleaner. It's a generic term
Well,
for
it
it.
moves, but it
But,
treats a different machine. Like,
Rapid arc
Interesting.
is
it treats one at a
copyright
time.
to Varian. So it's like vacuum cleaner or an Electrolux or a Hoover or something like that. That's the idea.
So that's what we're talking about with the screen. With the
So please
leads are
don't
going
call
back and
rapid arc
That's the
Electrolux or anything. Otherwise they'll think I'm nuts. Otherwise they'll think I'm nuts. So let's show you something here.
Okay, so we have a patient that, I can't remember what he's being treated for. I think it was a,
Static IMRT, like your gentleman there, where they do the rapid arc, they do the VMAT, and then turn the bed through 90 degrees and do static fields, right? They'll do one field from one end and then another field from another position. That is called static IMRT.
That's how all of mine are. My machine doesn't even have the arc.
No, well, that's fine.
Yeah.
So IMRT does not equal arcs. IMRT is the way it's planned. Okay, so let me go through this from pretty, isn't it? Needless to say, the guy who wrote this isn't an English speaker or is not English first language. Okay, so. Oh, yeah, go away. Okay. So this is 2008, but really,
I want to tell you about that patient.
oh yeah. What we were talking about here. So, they're talking about CT, MRI, and PET. So this basically gives you a 3D model. Everybody's seen a CT? Anybody seen an MRI or a PET? No? Get that. So this is an older version of a Varian machine. It is, looks like a Clinac 600, which is a forerunner of the EX or the IX, whichever you want to see. So here is a CT slice. So you've got certain models here. So this, and this, and this, and this. So we'll say that we're treating the prostate. Tell me what color the prostate is
On this picture?
on the picture. There's blue, red, yellow, and green.
Green. Yellow.
No.
Yellow.
Blue.
Red.
God.
Red. And why do I know that?
Because you know what
Is the
prostate
blue
looks like.
is the bladder.
Oh.
I didn't
So,
know what the green was. I thought that was.
The prostate sits right below the bladder.
Yellow in the right.
The yellow No, green would be the rectum. The yellow is probably the, smaller, I'm not sure why the yellow would be there. It could be just small bowel.
Well, you can't treat the prostate if the bowel's in the way.
Yes, you can, because you treat through it.
Could one of them be one of those space wars?
It could be actually the,
They won't treat the prostate.
Uh,
The bowel because you'll
seminal
let them have
vesicles.
diarrhea. They make sure it's all.
So, CT simulation, 3D treatment planning system, commercially available into the early 1990s. It's now firmly in place. So here is the MLC. This is what it looks like outside of the machine. These are the leaves here. Underneath this cover are the motors for each of these leaves. So this looks like 120 leaf. So you have half a centimeter MLC. So each of these motors drives one of these leaves. So you've got motors on this side, motors on this side. And each one of them drives one leaf. And the planner or the symmetrist will plan where the leaves have to be at any particular time. It gets even more complicated when we're doing arc therapy. We're doing VMAT because a lot of the time the leaves are moving constantly. Has anybody seen that? The leaves are moving constantly. So that is what happens. So each of these leaves at one particular point in time is moving.
I'm surprised somebody hasn't come up with a way to have an extra layer where they would be coming in from the other direction too, so you could actually, so you'd have some coming this way and this way.
It'd be far too complicated, it'd be too difficult to treat with that. So that's why sometimes when you're treating, especially VMAT, the collimator turns as well. So that your leaves are moving, your gantry is moving, your collimator is moving, and it's all computerized. So, conformal, generally used an increased number of radiation fields. So here is a plan. So you've got a field coming in this way, 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 and a field coming in this way. So it's a 5-field plan. Static fields, no arcs, just static. So you have shielding in each of these with MLC, but they wouldn't be moving. So improved conformity of the dose distribution. Conventional beam modifiers. Wedges, transmission blocks, and our compensators. Wedges used to be physical wedges. You had to put them into the machine. Now they're electronic wedges with 3D. Ignore IMRT for the moment. Okay, we're not there yet. So transmission blocks. We don't use transmission blocks anymore, we use MLCs. And they can be used for conformal, they just take the place of the Cerebin block. And compensator filters. Again, we don't use them very much in photon fields. I don't think anybody's using them in photon fields anymore. Protons are a different thing. We'll get into that later. So if you were not using IMRT to treat a prostate, this may be how you treat the prostate. 5 fields. 3, 4, 5. So here is ovarian with ovarian machine. And what do you notice, those of you who have been in clinic, what do you notice about the bed?
They have their own controls, but I don't know about this bed.
Sorry, say again?
The bed in clinic has its own controls, and that's what you use pretty much to move it. I don't know about this bed though. I don't see nothing.
Something different about bed.
It looks like it separates or something.
Pardon?
Does it separate?
Separate?
Yeah, it looks like the top part moves
Are there
away from-
accessories attached to the bed, or is that the whole bed?
That's the whole bed.
Permanent.
Well, no, there are certain things, there's certain parts that can come off. This can be taken off. This can be taken off. What I'm talking about is this part of the bed. There's something different between that part of the bed and, this bed and the ones you're used to seeing.
Is the material different?
Okay,
Is it not carbon fiber?
it is not carbon fiber. This is an older bed. This is metal. So to treat through it, you have to use this area. And this area has got, you remember me telling you about tennis rackets? This is what I was talking about. So the top of this bed from here to here would be removable and it can be turned around. And you'd have, so this would be the top of that bed. And you have one part which is full of, you know how they used to make tennis rackets out of catgut?
Ew.
They did.
No.
They did. It's now, of course, nylon. So it would have nylon,
Gut. Is that what she said? Like the gut?
so it would be something like that.
How is that strong enough?
Okay.
That's right.
And then the other one would be so these were called the tennis rackets. So you'd have this part where you could put
Ew.
an APPA chest or a pelvis or an abdomen. And if you turn it around or left it as is, you could treat oblique fields, posterior oblique fields, through these two edges. Could you see through them? You can see through them, yeah. They were nylon rackets, and they had mylar, which was plastic, on top. So the patient didn't get up to find his butt looking like a tennis racket or a waffle. So that's how it was done. So you had to move them, or you had to move the bed to match what type of field you had. Nowadays, with the carbon fiber, you don't have to care, or you do, but you don't have the same thought. Oh, okay. Does that make sense to anybody? Yes, no, maybe, don't care? Yeah, okay. So, this is certainly not conformal, but anyway, 1950s and 60s were conformal were starting. So basically, before the 1950s and the 1960s, you were treating with a fairly wide field of either a square or a rectangle. And you could shield a little bit, but it wasn't that much. When conformal came in, you could do a little more with shielding blocks. And in the 60s, or the early 60s, that was lead blocks. And you had to place them on a truth yourself. This looks like something that came out of the ark, but this is an orthovoltage machine. Now, even when I was training, and that was the late 60s, we never did this. We never were in the room with the patient. We were always behind the wall with a window made of lead glass. You had 250 to 300 kV machines. This one looks like a Siemens machine that you could place, and this came down to touch the patient. We actually got good responses, by the way. So, you know. And this is one of the first CTs that were used. So, 3D approach, calculation and planning. What are we treating here? Excuse me. We're treating the brain. Okay, yeah, you guess. So in this diagram, what do we see here?
Eyeballs.
Hmm? The eyes, yeah. What are these? Yeah. Yeah. No, the optic nerves. This is the optic chiasm. These are the nerves. So this is presumably the tumor. So we're looking, we've got all these beautiful fields that we're trying to find. The red is the tumor. Here. So we've got 4 fields in this case. No, not 4 fields. This one would work. So we've got a field coming down like this, and a field coming in like this. So we've got a field coming in this way, field coming in this way. What's this? Maybe read it.
Guessing it's related to the dose, but
It is. Let me just see if I can enlarge it a little bit.
Is it based on color according to the field?
No, it's not, actually. It's called a dose volume histogram. And what that does is you usually have a color code. So my guess is that this is the tumor dose. So all of these would have a dose and a volume. So the volume of this, which is presumably the tumor, is 100% of the volume, which is what you want, right? 100% of the tumor volume gets 100% of the dose. So these are the ones you have to decide what these are. And it doesn't give you any ideas here. But each individual spot, like this one, for example.
Uh-oh. Where'd he go?
Huh?
Where'd he go?
Who?
That was Steven.
I didn't even see him move. Okay. Okay, so
Such a fucking asshole.
I'm gonna put bells on you guys. Little bells that you put on cats. Anyway.
Do your cats have bells on them?
Pardon?
Do your cats have bells on them?
God, no.
It's really annoying.
No, we don't. And I'm not outside cats either, they're always inside. Anyway, so we'll say that this little blue thing here
Mhm.
is this. So if we're looking to see how much dose
They're bringing you treats.
this part will get, we look at the dose volume histogram and we'll see that 100% of the volume, follow this down, gets 100% of the dose. But if you follow this one down, it only gets 70% of the dose. So you usually have a little a scale that'll tell you which one of these actually works. Let me see if I can back. So there is nothing here. I'll get you a better volume, those volumes. So, 3D treatment planning systems in the 1990s. National Cancers, sorry? Somebody say something, okay. So the NCI wanted to evaluate 3D planning to make recommendations. So they came up with this 3D planning and has now become, or at that point, was standard of practice. So here we are again. Your laser lights. There's a red one here. Can anybody tell me what that is? It's a trick question. I don't expect you to know what it is because it's something that doesn't exist anymore. It's a back pointer. So you had the lasers coming from the sides, from above and from the side. This sagittal, the anterior, which if the machine's at 0 is hidden, and then the lateral lasers, okay? So one from each side, one from this side and one from the top. But you've got this red thing here too. So if you, let me go back and see if I can find it. Okay. So you see these? This and this? These are back pointers. So they put out a laser light that's usually different from the lasers on the wall. The lasers are either red or green. Who has red, who has green lasers? Red? You got red?
Green.
Green? Okay.
You have green?
So if
Yeah,
the
that's
lasers,
Oh, we have red.
it doesn't matter which one you have. The green
We were at the
ones
same place.
are more expensive than the red ones.
Yeah, you guys are very bougie over there.
But some people, in all seriousness, some people don't like green lasers because what happens if you're colorblind?
That's
Well, I mean, red would be an issue too, especially if you're red-green colorblind.
Well,
Yeah.
yeah, but more people are green colorblind than are red
green
colorblind. So, and some people just don't like the green lasers. They find them
I
difficult
don't
to
know,
work
red
with.
ones make me anxious. I feel like someone's got a gun on me at some point. with
I
the
didn't
red
even know that
lasers.
there was anything other than red, so.
I didn't
No,
know there was
I
anything.
there's green.
I didn't
so.
either, and we're in the same
Is it
place.
Well, I guess it doesn't matter.
Okay, so, just for talk's sake, the lasers here will say are green. There's lasers that come out of this and this that are red, so they don't get confused with the 3-point setup. So what does the back pointer do? Think about it. You have a front pointer, which is what? Front pointer is the center of the crosshairs. You know the crosshairs that come from the machine? The front pointer is where the crosshairs cross. And that's where you put your AP laser, or where you put your AP field. The back pointer is showing you the exit point of whatever field that you're set up with. So if you're set up here, the back pointer would show you the exit of this field, so it would be about here somewhere. So that's what is showing up on here. So you must remember that this goes to the central axis of the beam. Tell me what the central axis of the beam is.
It's the field, the axis of the field, the light field.
Okay. The center of the treatment field. The
Yep.
central axis. Yeah, the center, exactly.
Oh, my
But
therapist
no,
said
no.
it was not the same.
Yeah. The central axis of the field. So if you have a beam coming
Yeah,
down
my therapist told me that was not the same thing.
like this. You have a beam coming down like this. The central axis of that beam is there. And when that central axis meets all the other central axes of all of the fields, it matches at the isocenter,
But it's not the end.
right? So the back pointer is where this central axis comes out of the body. So if you have a beam coming in like so, the central axis is somewhere here, right? So what the back pointer does is it tells us where it exits the body.
And why is that beneficial?
Pardon?
Why is that beneficial? I mean, what
It
would-
used to be beneficial, we don't use it much anymore, but you have to know it because it's asked in the registry. Nowadays, when you're having IMRT and IGRT, you don't really need the back pointer anymore. But for those of us who can remember back before that, if you were angling a beam to treat a breast, you needed to know what angle it was coming out so that you could see. You can make sure it's the right angle. Okay, so this is what the planning people see. So we have this. This is the patient. This is showing you all of the different, this is a 3D, so that what the physician can do and what the dosimetrist can do is manipulate this so that it will rotate around and show you all the different planes of this area. You can actually manipulate the computer screen so it will do a 3D model. So here's all the fields. 1, 2, 3, 4, 5. 2, 3, 4, 5, 6, 7. It looks weird this way, but when you see it on the screen, it really is neat how you can turn it around. Okay. So 3D establishes the treatment, patient treatment position, including constructing a patient repositioning device, so an immobilization device. That helps with 3D planning, right? Contouring target volumes, critical normal structures. So when you get a 3D CT, the doctor will put on the target volume, the PTV. Then he will say, okay, give it back to the dosimetrist and they will do the rest. So he will contour using a computer system, contouring device to contour critical structures. So if we are doing, we'll go back to the prostate. If we are treating the prostate, the PTV will be the prostate. What critical structures would we have to contour?
The rectum.
All that.
Small bowel, okay.
The rectum.
The rectum,
The bladder.
yeah.
The oh, never mind. I was gonna say the fiducials, but those are
Seminal vesicles,
plates, I think.
because sometimes they treat them as well as the prostate.
I'm gonna
Now,
say head and neck,
the small bowel usually is only contour if we're treating the nodes as well as the prostate, so we'll be treating a fairly large area. So the dosimetrist will do that usually. He may, just for the heck of it, contour the kidneys if they've scanned high enough, just in case. So critical normal structures. Determining beam orientation. What is beam orientation?
Direction.
Yeah, direction from which the beam comes out.
Arrangement.
The arrangement. So, what would that mean?
Oblique spiral.
What does orientation mean?
Yeah.
Like the positioning of the beam at all times while it's moving.
No, we're not talking moving.
Well, I mean, in between fields, isn't the 3D formal multiple fields?
It is.
So if I get from this position, it's gonna be this orientation, from this
Yeah,
position, it's gonna
But
be
you
that.
said when moving, and that doesn't work, not while in motion, not while in motion, yeah. No, what you say is static fields, okay? As opposed to VMAT fields. So what you have to do is alter the angle. So if we are doing a 4-field pelvis, what are the normal angles for a 4-field pelvis? Right, left lateral,
So
yeah.
4 field box.
So 4-field box, that is correct, that's what it's called. Now, most physicians these days, even if they're doing a non-IMRT treatment, will not use a 4-field box. They will do something like 2 obliques and 2 obliques. So they do a right anterior oblique, a left anterior oblique, a right posterior oblique, and a left posterior oblique. That's what we do.
Trying to hold it.
Not working, huh? So that would be your beam orientation. And then you'd have to, we'll ignore the beam blocks because nobody uses them anymore. So we would have to decide or design the MLC leaf settings. And remember, the MLC leaf settings with a 3D conformal do not move. These go into one position and stay there. They don't do this. They will traverse in and they'll stay there. And then you'll go to the next field and the field MLC will move to another shape and stay there. And that's how it works. And according to the dose, so these leaf settings have to match what the doctor is thinking. He may do something weird. He may want some part of the treatment shielded where it might not need to be shielded, but he wants to do it anyway. Modifying the plan, beam orientations, apertures, weights, modifiers. Okay, apertures. What the heck is an aperture?
I know if taking pictures on a camera has something to do.
Yeah, so what?
There you go, Morgan. This is your time to shine. That's an aperture.
Well, when you're taking pictures, it's the depth.
It's
So
the depth.
It's the same with.
No, it's not. But an aperture is a fancy name for the field size. So how big is the field size? So you could have a 10x10 field size with shielding, obviously, which makes it smaller. Or you could do an 8x8 field size with shielding. So the doc might say, no, that's too small a field, I want it larger. So that's where the aperture would come in. Weights. No, it has nothing to do with the patient's weight. What are weights? Anybody
anybody got an inkling? No? Okay. To put it very simply, if you're doing, say, a 4-field box, you want 100% to the center of the field, right? So you would do how much from each field? Hmm? You want 100%? 25 from each field. But the doc comes along and says, no, that's not gonna work. Is there anything you can do? I want less from the AP. So the AP, he may decide to do 10% from the AP, which will mean that some of the other fields have to be half more. So it can actually move the isocenter by doing less from the AP and more from the PA. Does that make sense? So if you give 10% from the AP and 40 from the PA, where will that put? Will that move the isocenter anterior or posterior?
You're doing more from the posterior side? Yes, the posterior. Oh, I mean,
Could move it.
if the majority of it's going down towards the posterior side of things, I would think it would be posterior.
No, the majority is coming from the posterior.
So at the end,
So if you
say
say
the volume is weighted,
the fields are weighted,
entire field is weighted.
so the field is weighted, so the AP field is only giving 10% of the whole. So 10% of 100. But the PA is giving 40% of the whole, so it actually goes. And the other two can stay the same. That's what we saw. We'll discuss that next semester when we're doing the symmetry. And modifiers, that would be wedges or bolus or whatever you need to do. And so this can all get changed until radiation oncologist is satisfied. And normally, if you have somebody like an dosimetrist who works closely with an oncologist for a long period of time, they know what the oncologist is going to accept. So they can fiddle it until they think, yeah, this is good, he'll accept this. And then he hands it over and then, oh yeah, that's good, we'll go with that. Whereas somebody who hadn't worked with them for a while, he may hand them what he thinks is a good plan, but the doc will say, no, we have to change this or change that or change this.
we have a breast patient that uses bolus every other day,
Mm-hmm.
but instead of like traditional bolus, like they just use wet towels. Have you heard that?
Oh, yeah.
Cause she's kind of like, she's a bigger patient and like it kind of dips, and so they have a hard time.
Is pretty close to being one, which is water. Water is tissue equivalent, soft tissue equivalent. If you could get away with it, water is wonderful, but it gets messy, as you can probably figure out. But superflab is very close. So is paraffin gauze, or beeswax, or believe it or not, dental wax. You know, the pink stuff. However, wet gauze and or wet towels most physicists would frown upon using that. Because wet gauze and wet towels are not really tissue equivalent. They're close, but they're not really.
Use two of them.
And, go ahead.
It's different. I would just have a question about something different, but if you're not done.
No, go ahead.
Okay, so I find like where I struggle in clinic is when like after the CT is done and like lining up the images.
Mm-hmm. Yeah,
And-
nobody's
and-
expecting you to do that
and-
anyway.
Okay, and also obviously it looks different like than seeing like a person standing up and us like cut in half and us pointing, oh, this is the bladder, these are the kidneys and stuff. So is
Yeah.
there any way, because I still, even if I looked something up, I wouldn't know what I'm looking at.
Right.
Is there any way you could like put together a packet of like you just showed us a CT of the pelvic area.
Mhm.
Is there any way you could like put together a packet for us to study like a CT and point out different things like this is the rectum, this is the
Structures, yeah.
bladder, this
So
is
you're looking for CT anatomy.
yeah, pretty much because it's
Okay.
so hard for me to
We
like.
can do that.
been trying to.
She'll be like, "What is this?" And I'm
Yeah.
like,
Well, I
I don't
don't
know.
think anybody's really expecting you to know that, to be honest.
Like they'll be like, isn't that beautiful? And I'm thinking, I don't know what's beautiful about it, but sure.
Like, I get-
Like
those
every
friends
time
who
it
like,
comes up, I'm like,
do you
okay,
like
what's
it?
that? 'Cause
Well,
we
what
have
do
a
you
lot of
like
stuff. I've
about
never
it?
even heard the term fiducial.
Oh,
like,
yeah.
what are
Border.
fiducial?
I'm like, what are you saying?
yeah, and she's like,
I
"Oh,
think I went over fiducials.
I don't remember them
Yeah.
all. I mean, they're all different shapes and sizes.
they're like
Yeah.
the tiny little dots that you have to line up the fiducials."
Yeah.
But like,
Well, yeah. go
I
ahead.
don't know. Like, I feel like it'd be easier for me to understand lining it up if I knew, because it does look different than when we learn anatomy.
Oh,
You
yeah.
know, like
Yeah,
I
it
feel
is.
like I have a good understanding of anatomy until I look at CT.
CT anatomy.
Yeah.
It's called cross-sectional anatomy.
Yeah.
Yeah.
So, and I was just
Yeah.
looking at them and I was
Sure.
like, okay, it looks like a
You can do
brain. I don't know what that
Do
is.
that, yeah. Fiducials, just because you mentioned it, fiducials are anything that is put either on the body or in the body to help you position.
I feel like
So,
they ignore it
that's
a
what
lot.
it's
Like,
called.
I'm like, what are those? Oh, those are the fiducials, and then they just align it to other things around.
Well, it depends on what we're using
I think
the
it's like
fiducials for.
Sparkles. Big sparkles.
So, are you talking
Like a different name for
CBCT?
everything.
Okay,
That's
Yeah,
what seems
so-
like, you know,
CBCT
that's not what it is.
CBCT is meant to position soft tissue. So for prostate, especially for prostate, some prostate patients will have prostate beads.
I've seen that.
So they're there to position. However, because the prostate moves,
That's what.
the fiducials move. So some departments will have you match the prostate seeds from the CT and the cone beam CT, match them first, and then go with the prostate. So it may not be the same thing. Some physicians will say, I don't care, match the seeds. And that's their choice. Some physicians will say match bony anatomy. And I had a running argument with a physician at one point, which is probably why I left. Anyway, that CBCT is not meant to align bony anatomy. That's what KB beams are for. You can get a beautiful position on bony anatomy, And then if you look at the soft tissue, it's way out there. And I'm talking a centimeter, which is enormous for cone beam CT. So it all depends on what they're doing, what they're positioning to, or what they're matching.
Maybe I'm missing when they're switching between cone beam and KB.
Well, no, you do either one or the other.
Right.
If you're matching, if you're doing something like a prostate, you match soft tissue. That's what it's meant for. Don't even go near the KB beam. Don't even go near the bony anatomy. It will be off. You can, 99% of the time, you can't match soft tissue and expect the bones to be in the same place. So it's not true. So it all depends on what the policies are in your department, what they are matching to. Should be soft tissue, but it depends on the physician. And since the physician is the one who takes the heat if it's wrong, then you go with what the physician wants. You can argue, you can discuss it with them and say, wouldn't it be better if? And if they say, no, I want it done this way, okay. The department I worked in California, one physician demanded that we match the cone beam CT to the bony anatomy, and the other one, soft tissue. So you have to remember whose patient's who. Okay, so talking of fiducials, this is actually for immobilization. This is similar to the Halo device. So this is a fiducial, only it's a special type of fiducial that you put on when you're doing the stereotactic. This is actually attached to a mouth bite. So the patient puts a mouth bite in, and the fiducial is attached to that mouth bite. And there's an infrared camera up here, and it tracks where the fiducial is. And that's how it's positioned. And here comes this is a PET. We've been a bit that's as far as it goes. So that's a PET scan, a color one. Here's a black and white version. So anything that's black in a PET scan or high color, like here for example, is bad. It usually shows cancer. So here, here, and here, and a little bit here. So here, here, here. The bladder, we don't worry about. Why?
Filtration.
Pardon?
It filters out.
Yeah, basically that's where the excess is removed. The one thing that, just out of curiosity, is that if you're doing a PET scan, or even a CT PET scan, you have to provide a washroom or a toilet actually for patients because they are radioactive, therefore their urine is radioactive for a certain length of time. So again, physician or dosimetrist. CT MRI, so we would have perhaps we would do the CT and another department in the hospital would do an MRI, and we would put them together. Anybody remember what that was called? Fusion. Yeah, we'd fuse them together. So you get the CT and an MRI on top of each other, and you would get the values for both. This is a CT. Hey, okay. So this is this is the key. So you notice that the red is 120. The orange is 110. Yellow is 100. Sort of strange green is 90. Light blue is 70, and dark blue is 50. So here's a head and neck.
So
1, 2, 3.
the red means they're getting 120% of the dose prescribed to that area?
That depends on how the prescription is written. If the doc decides to do 120 for the total, then everything would be, normally what we would do is prescribe to 100%. And the 120 would be small areas. Here is far too big. So the yellow is this. And here. Anything inside this yellow. Here, 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 and here. So anything inside that yellow is 100%. Now normally we'd have hot spots, which would be 110, maybe 120, but very rarely.
So those would be like a boost or
large.
anything?
No. This is a bad plan. We would never accept that these days, even for a 3D. We would never accept that. If you're prescribing to 100%, which most people do, this area, which is 120, would be unacceptable. And the orange would be unacceptable as well. It's a bad plan, to be honest. This is much better. You see the little ones here and here, that would be acceptable. This little one here and here. This would probably be not acceptable. This might be. Depends on what you're doing. And we'll go into all that next semester when we're doing dosimetry. But I'm just giving you an idea here. So beam technique. Beam's eye view. What does beam's eye view mean?
It's the view straight down from the pantry.
So you're in the beam looking down on the patient. That's the beam's eye view. So here is wedges, lots of wedges. So this is one, this is one, this is two. Here's another one. It's 1, 2, 3, 4, 6 wedges on this. So design the field shape. it's not a very good one. So this is 70, does that say 8 gray there? Let me just bring it up a bit higher. Yeah, so this is not bad. This is a really bad one. This is just showing you what, that's worse than useless.
That's 78.
Yeah,
Okay.
and the other one's 70. So you want to design the field shape, first of all. Do you want to use blocks? Do you want to use multi-leaf collimation? You have to decide what we're doing. So here is actually a good one. So you have this field set up here, huge fields, right? So this is this. Then we've got this field. Then we've got this field. And then we've got this field and this field. So what do you think we are treating here? I'm going to take a guess anyway, but you guys can take a guess too. What do you think we're treating here? This, ignore this one. This is one that I'm looking at.
Inverted Y, so lymphoma.
No, it's not an inverted Y. This is one large field, then you've got another field here, another field here, and another field here, and another field here. This is something probably in the realm of, because it goes down so low, I would say that this is something like a vulva or a vagina, because it goes down so low. And if we're treating gynecological fields, what are we treating here, for example? What do you think this is? This is basic anatomy, guys, not CT anatomy, just basic. Down here?
Fallopian tubes. I mean, that stuff gets all squished up.
No. This is, pardon?
The cervical nodes for pelvic?
Pelvic nodes, yes, you're closer. What kind of lymph nodes are down here? This is your groin.
Ischial nodes.
Pardon?
And renal?
Inguinal. So this is 3 areas. This is a large field, a smaller boost, and an even smaller boost. This is the large field. All of this. Then we treat 2 smaller areas, these 2, to do the lymph nodes. And then we come along and say, okay, but we need to do, say, an electron boost to the nodes, because you can get more superficial. So we would treat this area and this area with electrons. Those calculations. Can anybody tell me what these are? I don't think you've come across those yet. These are isodose curves. If you have a spare minute and the symmetry doesn't look that busy, go in and ask them if you can look at some isodose curves. Maybe later on. These are isodose curves. The isodose curves are usually curved like this. And each of these lines joins points of the same dose. So if this is 70%, then everything along this line is 70%. And this might be 60%. So everything along this line is 60%. And they go down, they start off at 100 at D max, and then work their way down. So we set those calculations, we perform the dose calculations, and we finally get a dose here. So you get 4 fields, it's a 4-field box. 1 field here, 1 field here, 1 field here, 1 field here. So, here's 2 plans. This one and this one. Which is the best plan? Just looking at it, what would you say was the best plan? And you have to tell me why.
I don't know why.
There's no right answer. Just, it's all in the eye of the beholder. So, to your eye, which would be the best plan?
The one on the left.
The one on the left, so that one?
Yeah.
Why?
Because it looks all together.
So it's more concentrated.
Yeah.
It's smaller, right? Okay.
The other one looks like scattered.
What about this one?
Yeah, it's a little fairly even.
Okay. But if you look at it, although these are little fingers going out, here is your legend. Okay, so the purple, the red is 100% here. So everything inside of here is 100%. Green is 95 here. Blue is 80 here. 60 is dark blue. And 50 is yellow. So you notice that the yellow here, this is devil's advocate, just so you know, here is going down further here than this one is. But here, of course, it's gone down further than this one is. And we have a problem here. Look at this. What's this? Not spinal. Spinal cord. Should it be getting 95% of this? No, definitely not. You'd get shot if you showed that to the doctor. If this is true. If this is just not a computer glitch. Because there's nothing here. So it depends on what the dog wants to do. You're probably right, this is probably the best one, but if you could smooth this out a little more, this is more compact than this one, except for the yellow. So it really does depend on how you're working. Review and document. And then we verify the plan and treat. So what are they putting in here? What's this girl doing? You can't see it.
Oh, is that a ruler?
Yes. So what is she doing? What is she checking?
SST.
The SSD. Right. And what's her colleague doing?
Oh, that's the, well, I usually put that in for the electrons.
Pardon?
Put in a port film.
No,
Well, that's called,
you don't put a port film in there, you put a port film down here somewhere. She's putting in blocks. You see the tray? There's a tray in there. So she'll be putting in blocks. Ah, cute. Okay. Yeah, that's okay. Yeah, before we get to. Okay. IGRT, image guided radiation therapy, and this is in prostate cancer. So, treatment planification. Yeah, it's a good job he's not an English speaker. Okay, so you have a patient, you do the CT. Now they're putting in the patient feet first. Is that normal? Has anyone actually had the chance to see a CT done yet? 9? Yeah. Which way did they normally put the
So-
patient in?
The therapist said we try to request that they do it head first, but sometimes if we don't let them know, they do it feet first, and it just makes everything a little more complicated.
It does. So I'm presuming with what you said, the treatment therapists are not doing the CT.
Sometimes, they have like someone who's only CT, that's all they do, they stay in there. But
Yeah.
the lead therapist and the other therapists that do treatment sometimes go in there. And
Okay. So you're right. 99.5% of our patients, we do head first in CT. Give me something that wouldn't be treated head first. Or CT head first.
The bottom of the foot.
The foot, actually,
I was just about
probably
to say.
till mid-thigh. If you were treating any of the leg, you'd probably put them in feet first. But anything else, you put them in head first. What's the problem if you didn't realize that they were done feet first and you treated them head first?
Be off.
Pardon?
be on the opposite.
Yeah, everything would be reversed, right? So you'd be treating the wrong side. You'd be shielding the wrong area. So, yeah, it's probably yeah. Normally, you would treat head first unless told otherwise. So planning, so the CT is done. Then the CT images and the data is all electronically shifted across to the symmetry. And then the planning starts. And you have the GTV, the CTV, and the PTV. All of those are done. And eventually it gets to the treatment. So we are doing here a cone beam CT by the looks of it. What equipment can be used to do IGRT?
KV imager.
Doing what? Well, How are you gonna use the KV imager to do IGRT?
I still don't understand the question. We
Okay,
pull it out and make sure that the filters are the correct size, and then they push buttons in the room that I don't push, so I don't know.
you're talking cone beam CT.
Most of ours, they use the KV imager. I would say majority.
So they
of
would
ours.
be doing an AP and a lateral film? An AP and a lateral image, excuse me?
Yeah.
If you're using KV images, you would probably just do an AP and a lateral. Or in some cases, you may do obliques, but, so what are the KV imagers doing? What is if you take 2 KV images, what are you aiming to see?
Their current position.
Static.
Treatment margins and making sure you're lined up.
No. KV imagers, you're looking for bony anatomy. That's all you're looking for on a KV image. Now, if you use the other part of the KV imager and the other software, then that would give you a cone beam CT. And that would be looking at soft tissue images. So the KV imagers are looking at bony anatomy. Using the cone beam CT looks at soft tissue anatomy. What other things can you use to do IGRT? Remember, it's image-guided radiation therapy. So what other things give you an image? You've got KV images, you've got cone beam. Those are the most common. What else?
I've read ultrasound.
Ultrasound, yeah. Has been and is still used in some cases.
and MRI.
Ultrasound, MRI, yeah. What else?
Fluoroscopy.
If you had a fluoroscope in the treatment room attached to the treatment machine, then yes. If you had to move the patient, no. The idea with KV imaging and with IGRT is that you have to image the patient on the treatment machine in the treatment position. So anything you have to move the patient off or on doesn't work. So what else is there? What else is there on the treatment machine that you could use for imaging? This is your KV imager,
Your MV image.
which can be used for either KV imaging or cone beam CT. Yeah, your MV imager. You do the MV imager for portal imaging once every 5 treatments. Has anybody seen that done yet? Yeah. So that can also be classed as IGRT. Because if you take an MV image just before you treat the patient, then that is an image-guided radiation therapy field. Although it's not usually meant that way. So different in, yeah, target positioning, oh yeah. So, determines, so this is a CT scan. So it determines the reference position of the prostate throughout the treatment. So here is the prostate. Remember, the prostate sits behind the symphysis pubis. That's the sort of normal position. In the treatment, the prostate position changes with respect to the reference position. The prostate moves. So this is one of these things that before we had IGRT, we have to do a larger field than we do these days. because we wanted to make sure that the prostate was still in the field, no matter what it moved. So here you have, this is from CT, this is from, we'll say, cone beam CT. See how far it moves. So what would we do then? You would superimpose one on the other and move the treatment field till it matched our CT. That's your cone beam CT. So, why may the target be elsewhere? Mispositioning. So this is interfraction. Interfraction means in between the treatments, right? So you're treating them on Monday, and then you're treating them on Tuesday, and then on Wednesday, etc., etc., etc. So this would be interfraction. Organ motion. Just because you do a cone beam CT right at the beginning of treatment doesn't mean to say, oh, the prostate says, okay, I'm here, I'm gonna stick here. No, it moves a little bit while you're actually treating them. And then shape change, again, interfraction, interfraction. So this is mispositioning, organ motion, intrafraction. So this is while you're treating them. And then shape change, interfraction. So if you look at the prostate, it may be slightly different shape from Monday to Tuesday to Wednesday. It's another reason why we do IGRT. So may result in absorbed dose in the volumes of interest in organs at risk that do not correspond to the theoretical dose plan. So the dog says, okay, I want 7,800 centigrade to the prostate. And the bladder can only have 4,500. And the rectum can only have 4,000. However, the doses may be slightly different. Maybe the bladder gets 5,000 because you haven't accounted for the shift in where the prostate is, because if the prostate moves, everything else will move too. The mobilization systems, any of these look familiar? This is a mat clock. So is this. A weird one, I must admit, but yeah. Has anyone seen anything like this? No. It's a new system. They actually attach to the bed. This is for the patient's knees. Of course, you wouldn't use these when you treat the prostate, right? Why not? Why don't you use knee cushions when you're treating the prostate, or anywhere in the bladder, anywhere in the pelvis for that matter? Because? Yes, but that's not the reason.
It tilts your pelvis.
Pelvic tilt, yes. So even although this is attached to the bed, and this should stay put where it is, you can't always tell that the patient is exactly where you want them to be every single day. Because he could be moved up a little bit or down a little bit, and then the pelvic tilt will move. Okay. How can we know the position of the target? Well, okay. So IGRT is the use of the image in the actual treatment room as a tool for tracing and verification of the tumor volume immediately before or during treatment. So, portal imaging. It's a 2D image, but it still counts. CBCT, great. CT scanner, okay. However, we'll come back to that. Exact track. This is one which there's not a lot of them in this area. We'll come back to that one as well. So ultrasound, you can use as well. Majority of the ultrasound IGRT systems would be used for prostate. And not to find the prostate, but we wouldn't ultrasound the prostate. What would we ultrasound?
Bladder.
The bladder. Because the bladder is easy to ultrasound and the prostate sits just below the bladder. So you have this bladder edge which sits along the prostate. So if you get the bladder ultrasounded, then you can see the edge of the prostate sitting there.
What's the source for portal imaging? Where is that coming from?
Portal imaging is the MV image.
What's the arrow pointing? I mean, I know it's pointing to the MV, but where is it coming from? That's what I'm
Oh, no, this is just showing you.
showing us where
Yeah,
it is.
yeah. This is just the MV imager. The MVs are coming from the treatment machine.
That's what confuses me is CBCT is the same to, what's the word I'm looking for? You're using the same equipment on both of them, so what
No.
exactly makes them different?
No. The cone beam CT is KV images. It's like doing a CT image. It's like doing CT slices. That's exactly what it's doing.
Isn't that coming from the gantry? The KV imager I thought was something different.
No, this is actually the MV imager. This is coming from the MV imager. Although it says cone beam CT, this is not a cone beam CT. This is an MV image coming from here.
Okay.
So ignore that.
So cone B is used with the KV imager.
KV imager has two lots of software. One lot of software does actual KV images like X-rays.
Like single
Yeah,
films?
yeah,
Well,
like
films.
images, yeah.
Right.
Like normal X-rays that you would get in a doctor's office,
Okay.
those types of images. Although much less.
But that would not be considered IGRT?
It could be considered IGRT.
Does it come up immediately?
Yes.
You would- okay.
Oh, yeah, you can bring them up. The second lot of software gives you cone beam CT. So it converts all of these KV images. It does a complete,
All the way around.
Right.
I've seen that.
and it will convert all of these images to a CT slice.
So when they're saying is it the DRR, the digitally reconstructed,
Radiographs.
is that from the individual KV images?
This is from the CT. The DRRs are manipulated by the dosimetrist from the original CT. It's like taking a screenshot from a video. They take the image from the CT. Now we have CTs here, but it is not a cone beam CT, excuse me, it is not IGRT because to
Not doing
use the
radiation.
CT, well, what?
You're not treating them, well, no, never mind, CBCT is right, well, CBCT is right before treatment, like literally right before
Yeah,
treatment.
Right,
Whereas that one is
yeah,
another
so
time, another place.
the reason why we say that CT cannot be used as IGRT is that you'd have to have the patient taken off of the treatment bed, put on the CT scanner, and do it that way. And that is not IGRT because it has to be there. Now, there are some older machines. There are some machines which use what they call CT on rails. So you have a CT scanner in the treatment room, and the machine will be able to be moved out of the way and the CT scanner taken over the patient and the CT done. But I've never heard of those being used in the last 10 or so years, so. As a rule, CT scanners are not counting IGRT systems. Now, this exact track,
Get that.
yeah. So the exact track has got sensors in the floors here and sensors on the ceiling here. And the patients have fiducials inside. So the exact track can actually track the patient's movements before treatment and actually during treatment as well.
We go through all the steps of setting them up, line them up with the lasers, and then we line them up to the numbers on the screen from the plan.
Yeah.
And then they're like, okay, now line it to that. I'm like,
Yeah.
it just seems like you're undoing all that work you just did. It's very confusing, and all the time I go in there, they're like, don't worry about it, it's just an accessory, it's not really necessary, but we have to use it a certain number of times, and I'm like,
What, the cone beam CT?
no, it's called Vision Art, I think it's called.
Oh, yeah, Vision Art, yeah, okay.
So, yeah, it's basically, they highlight an area of the patient that they wanna focus on, and
Right.
then I reposition the patient after all that, again, to
Yeah.
get that lined up,
Mm-hmm.
and then if they move out of that little space at all,
Yeah,
alarms go off.
that's right, that's exactly the same thing. It's a version of the same thing, just made by a different manufacturer. So basically, IGRT systems include MV imager, KV imager, cone beam CT, exact track or something similar, and ultrasound. Those are the 5 IGRT systems. What has been done until now? Okay, ultrasound, oh yeah. So just what I was, the Siemens machine uses an MV CBCT rather than a KV CBCT. So it actually uses the imager, the MV images, or the NV, excuse me, let's start that again. The Siemens machine used to use the MV energy, whether it's 6x or 18x or whatever it is, to do the cone beam CT instead of using the KV energy to use the cone beam CT. Does the same thing, just a different way of doing it. And the seeds. Fiducials. They're implanted transrectally into the prostate via ultrasound. So there's usually 3 or 4. The idea is that if the prostate moves, the seeds move. The trouble is, 9 times out of 10, the seeds move independently of the prostate. But the theory is that if the seeds move, the prostate moves, and the prostate moves, the seeds move. And you can actually see these a lot better on cone beam CT, and you can actually superimpose them a lot better. You're looking very quizzical.
I'm trying to figure out, are those seeds around the outside of the prostate?
No,
In the
they're
yellow?
inside of the
No, in the
prostate.
yellow, like where are those blue dots in the yellow outside of the prostate?
That's, I think, supposed to be just soft tissue.
Oh, okay.
So this is the prostate here.
Right.
So these 4 little things are the seeds, and they're only tiny. They're about this size. So here are the seeds. Actually, why don't we stop this and we'll just continue this after our break.
Yay.
I'll leave this up. You can waken up now.
Okay.
Come on, it's not that bad.